Hello, everybody. Good morning. Hope everybody can hear me and hopefully you can see me. I'm Dr. Tommy Heisler with the Houston Area Safety Council. We want to thank everybody on the webinar today. Very excited to have you and share some insight with you. The goal of the webinar today is to specifically address the COVID virus as it relates to our companies and our employees. I'm going to flip back and forth on a few slides that I think you can see before I introduce our speaker. Like I said, I'm Dr. Heisler with HASC. I think most of everybody on the webcam today should know who the Houston Area Safety Council is, at least familiar with what we do here. But our mission is to build safe workplaces. And a safe workplace not only means safe from falling objects or safe from machinery that you're operating, but it also includes being safe from any unseen hazards. And I don't think anybody would argue that this virus is an unseen hazard in our work environments right now. HASC, for its part, is doing a lot to make sure that we can continue getting people qualified, certified, trained, and that any injured employees are getting taken care of. We want to make sure that the industry stays alive as much as you do and that it stays functional. So we're trying to do our part as much as we can as well. You can see a full list of everything that HASC is doing on our website. You can also sign up for alerts and information. Should you want to ask questions during the webinar, feel free to enter those questions in the question box that should be on everybody's screen there. We're going to answer the ones that were already sent to us first, and then try to get to everybody else's questions that you've inputted live towards the end of it. But our goal is to continue to keep our doors open until the last employee has been taken care of. Like I said, many companies on this call, just like the Houston Safety Council, have been identified as a critical infrastructure workplace by Homeland Security. So we understand that, governing agencies like OSHA, for their part, have not waived safety and health requirements. So we want to make sure that we're allowing that training and certification to continue as much as we can in a safe and clean environment. I would venture to say that everybody on this call is eager for our industry to get back to normal, to get back to full operations. We understand that it's not a good time right now for our industry. I get dozens of calls every day about what to do with employees that might have symptoms, or maybe that employee has a family member that tested positive for the virus, or they're wanting to come back to work. And these are all good questions about real scenarios that employers are facing, and the answers to those questions are not always easily available. The CDC does not come out and hold a press conference and answer questions like, should I be taking the temperatures of every contractor entering my job site? That's just not on their radar. So to help answer some of those medical type questions, HASC wanted to offer this webinar to our community and industry. As of this morning, we had almost 600 registrants for this webinar, which is a little intimidating, knowing that 600 people are listening and hearing what I have to say and what Dr. Delclos has to say. But luckily, we definitely have some good expertise with Dr. Delclos today that we can try to have a good conversation and hear what he has to say. I looked at all the registrants on the webinar and what company you all work for, and I will say that the variety and degree of expertise on this call is very amazing. There are people from all industries, and it appears that we have representatives from most of the major petrochemical companies in this area that are participating, so we're very excited. Dr. Delclos is going to do a very short presentation on some current updates, but mainly we want to open it up for questions and have a discussion. Again, like I said, many of you already submitted questions, and we're going to answer those first, and then going to get to any questions that you might have inputted. Now, I'm going to introduce Dr. Delclos. Very honored to have him as our featured speaker. I would read to you Dr. Delclos's full resume, but it literally was about 47 pages when I opened it. But that shows you the amount of expertise, experience, research, and knowledge that Dr. Delclos brings with him. In short, Dr. Delclos is a professor of occupational and environmental medicine at the University of Texas School of Public Health in Houston. He is triple board certified in internal medicine, pulmonary medicine, and occupational medicine. He holds both a degree, a master's degree in public health, as well as a PhD in health and life sciences. So his knowledge is very unique in that not only is he an expert in lung disease and lung infection, which COVID virus is, but he is also an expert and professor in occupational medicine, which allows him to bring that perspective as it relates to our workers and our environment. Dr. Delclos is currently serving on a Houston Medical Center incident command group for COVID-19 and is truly a treasure trove of information. So honored to have him speak with all of us today. So without further ado, I'm gonna change Dr. Delclos over as the presenter, and he's gonna share some slides with you.
Okay, well, hopefully everybody can hear me. Tommy, can you hear me okay?
I can, yes, sir.
Okay, very good. Then we're going to go ahead and get started. Let me see if I can do this. This is the trickiest part of the presentation is this one. So now, can everybody see my slides? Tommy, can you see my slide? Okay, yep. So as Dr. Heisler said, I'm not going to spend a lot of time talking about it. I mean, we are literally inundated with information on COVID-19, on the novel coronavirus every day through a variety of media. And I think you know the basic facts. So this was a viral infection, an infection to a completely new virus that humans have never been exposed to, that began probably, or at least the first cases were described in December of 2019 in China, and then since then has been rapidly spreading to all over the world. So we know that it is a highly contagious disease. We know that the fatality rate, the likelihood of dying, is higher than that of the seasonal flu, even though more people get the flu worldwide, and therefore the absolute number of deaths attributed to the regular flu is higher. This one is more contagious, and the mortality is about 10 or more times that of influenza. So just a few slides that's all I'm going to say about that, and then through the questions, I guess we can drill down on the details. Let's see. Why is it not clicking? Okay, so as of this morning, the number of cases in the world is approaching 500,000 now. This is a website that you've probably seen on TV. It's called the Johns Hopkins University website. It is doing a tremendous service by keeping us up to date. It started when the first cases were in China and has been a constant reference for all of us to keep tabs on situations. It's not the end all and be all, but it gives incredibly up-to-date and valuable information. So worldwide, we're at about almost 500,000 deaths. I'm pretty sure we'll be there by tomorrow. Excuse me, 500,000 cases, confirmed cases, of which there have been 22,000 deaths. More locally speaking, in the US, as of this morning, there have been approximately 69,000 cases, with a little over 1,000 deaths so far. These cases are not distributed uniformly across the United States, but there tend to be some states that concentrate more cases and are known as hotspots, particularly New York. I think we've all been hearing about New York, but early on it was Washington State and California. The New York, New Jersey area is now the one that harbors the largest number of cases and deaths in the US. Here locally in Texas, as of this morning, we have about 1,300. Now this is I believe this is confirmed and presumed cases. When you have a presumed case, it means that you've been tested and the test has come out initially positive and it's waiting for confirmation. Texas, proportional to that number of cases, has a relatively low death rate at 17 so far. Here in the Houston-Harris County area, we've got about 185 cases and 1 death so far. And if you include Matagorda County and the surrounding counties, we are at about 400 cases and 1 death in Matagorda County. So far, the number in the Houston-Harris County area is manageable, although hospitals are filling up, and the deaths so far are low, but we don't expect that to last long. It's going to be very, very interesting to see if the measures that the hospitals have been putting in place now I've been working with the medical center hospitals for about a little over 2 months now, putting in place response plans, and every day we have to tweak them because something new has arisen. But we need to see if these low numbers, they're going to grow. They're going to grow definitely, but we'll see if we've been able to blunt the growth thanks to all of these response plans that we put in place, together with the city ordinance that I'm sure everybody is now familiar with, that the city of Houston implemented just a couple of days ago. As Dr. Heisler was mentioning, there are some businesses that are considered critical to infrastructure. The language in the city ordinance is that they're called essential businesses. Essential businesses are those that really allow the critical operations of the city to continue. And actually, if you look at it, the list of businesses that fall into this essential category is quite broad. It's not only hospitals and maintenance and supermarkets and pharmacies, but there are a number of, including construction businesses, that are that fall under this rubric. However, for those essential businesses, the same city ordinance, under its the program name is Stay Home, Stay Safe. It does ask those businesses that continue to operate to keep in mind and to apply 10 principles. So they're taking measures even within their own companies, although they're allowed to continue operating, it's still not business as usual. So let's just quickly go over these 10 principles because they are important. And if you fall into those essential businesses, you should be applying this to the extent, to the greatest extent possible. So number 1 is you don't have to have everybody on the work site. You have to, within your essential business, you have to identify which employees are critical to the operations and which of those can safely work from home, contribute to the operations of the business, but don't necessarily need to put themselves at risk. So we employ video technology, just like we're doing right now. Normally we would have had this probably, maybe not, well, actually it was originally planned as a face-to-face meeting, but we're abiding by using video technology as well, to think about creating a safe work environment for all of these employees that do have to show up for work. That means applying the CDC principles of social distancing. You even in their office areas, you should abide by that and keep people separated at least 6 feet. Encourage all of the other measures that CDC is implementing that you've already heard about. Requiring sick workers to stay home. I really need to emphasize this. It's a little bit difficult sometimes to know who to send home and who to keep when they have some symptoms. One of the things that makes it difficult in the Houston area is that we are still at the tail end of the flu season, and we are also just really ramping up for the last 2 or 3 weeks for the allergy season. A lot of the tree pollens, especially cedar, oak, ash, are out there now, and there are a lot of folks that are allergic to that, and some of those symptoms may mimic symptoms of COVID. But it's better to be safe and sorry and to require workers that are sick to stay home. You can always send them to a healthcare provider, and that healthcare provider may be able to distinguish between allergies and an infection. But it is important to not have those folks come to work so that they don't spread whatever they have to other folks. There's been a lot of work, a lot of talk about paid sick leave policies, especially with the new stimulus package passed by the Senate last night. I think it's pending approval by the U.S. House of Representatives today. There's some language in there as to who qualifies or what some of the guidelines are for paying folks who have to be off work. Encouraging proper hygiene. This is more than just the social distancing. This is emphasizing good hand washing, 20 seconds at least, or if you want to, you sing the birthday song, the happy birthday song twice. That's about 20 to 30 seconds, but you can't speed up. You can't sing it really, really fast because that's still not going to be 20 seconds. Making sure that when you cough into your arm or into a tissue. Making sure you get rid of tissue paper that somebody you've just coughed into is disposed of quickly, and that you maintain surfaces like desktops and high touch areas like handlebars, doorknobs, handrails, things like that clean. The COVID virus, the coronavirus, is actually kind of a wimpy virus in the sense that common disinfectants that you can buy at any supermarket will take care of them. You don't need to go to hospital grade, hospital grade cleaning disinfectants. One thing you may want to do though in your business is to step up the frequency of cleaning that's done by your housekeeping crews, just as an added measure. And that is one of the things that's recommended under the 10 principles. Creating alternative teams. This means being creative about how you work your shifts, having teams that are cross-trained to the point that if one team gets sick, and remember that's conceivable, if one person on a team gets sick, they could conceivably spread it to other folks, and within a matter of days you have an entire team that's affected. Well, at least thinking ahead and creating alternative teams that could replace that team if it needs to be replaced, because they have to, the ones that have been exposed have to go into home isolation or quarantine. Restricting on-site access. At the medical center, I can tell you that over the last week to week and a half, we have already been implementing this. We're making difficult choices. We are restricting, for example, the number of visitors that can see a patient in the hospital. And sometimes that's tough because family members want to see, especially people that are very, very ill. And but for the safety of other patients and for the safety of the employees of the hospital, we have to restrict that. There's a one visitor policy in place in most of the medical center hospitals now. We also screen everybody coming into the hospital. I've been screened I don't know how many times this week. Every time I just go in to Methodist or one of the other hospitals, there are teams there that are blocking the entrances, and you don't get by unless you have your temperature checked and you have a few simple questions asked. It takes less than 30 seconds to get through that process, as long as there's not a long line. And it's all geared towards protecting folks, people who have a temperature or who respond positively to any of the questions regarding travel, or whether they've been around a known COVID positive patient or have certain symptoms, primarily cough, fever, shortness of breath, are not allowed entrance. They're sent to their primary care provider, or if they look really, really sick, they may be sent to the emergency room, but they are limiting their access. So it's important to think about, from the context of your business, what kind of restrictions would be reasonable to undertake. And I know you guys have a lot of clients visiting you, et cetera. I'm guessing that a lot of those interactions can be done by video technology. That doesn't mean that there aren't other things like delivery of supplies that can't be done, but even when you deliver supplies, there are measures that you can take so that those things, those materials are delivered in a way that's safe and without endangering others from the standpoint of likelihood of transmission. Discontinuing all work-related travel and requiring reporting of personal travel. From a company standpoint, it's actually quite easy to discontinue work-related travel. You just order it and it better be done, right? It's a little bit tougher to keep tabs on personal travel. There are, folks go on vacations. Most companies encourage strongly that employees report that travel, but sometimes that's not going to happen, especially if they view personal travel differently from what you do. So for example, there are some hospitals in the area now that are, what they mean by domestic travel is no farther than 150 miles from Houston. That's the radius. And so, you know, we tend to think of travel at the beginning of this epidemic as mainly to China, to countries that have high cases. Then we move to including in that list states in the US that have high rate, you know, that are hotspots for the disease. It's difficult to prohibit that in the US because of the type of democracy that we are, but certainly discouraging travel for any reason right now seems to be the prudent thing to do. And requiring reporting of personal travel can be implemented from a company, but you got to have some sort of backup plan to make sure that that is enforced, that folks are compliant with that. And then finally, establishing a mechanism for anonymous reporting. There are a lot of folks that are concerned about COVID that may see other co-workers that are not abiding by safe practices, and they need to be able to feel comfortable reporting something that they have seen that is not correct, but without fear of retaliation or even of losing their anonymity. So those are the 10 principles. You can find a lot of information on this on the Greater Houston Partnership website. And that leads me to my last slide. Again, we are inundated with information on COVID. Not all of it is reliable. And especially on the internet, when anybody can post anything, anytime, anywhere, you have to be especially careful to make sure that your information comes only from reliable sources, especially if you are going to make business decisions based on that. So on this slide, this is just a handful. There are other reliable sources, but in general, things that I think are useful for you, and these are sources that I consult almost every day. The previously mentioned Johns Hopkins University map. It's a GIS system, a geographic information system that I showed on my first slide. It's updated every few hours, actually, as cases accumulate. And then your health departments at the state level, the Texas State Department of Health Services, your county. I didn't put up the websites because I imagine with this number of attendees on this webinar that you're from all different counties. So just Google your county's name or your county's name and then say health department and it should pop up. So state, county, and your city health department websites. If you're from a very, very small town, you may not have a local health department, but you certainly have a county health department. And then guidelines on what to do. You know, where can you find useful, practical information that is reliable, that is scientifically valid to the extent that we know, and there are some things we don't know yet about this virus. The US Centers for Disease Control and Prevention, or CDC as we know it, has a number of very, very useful guidelines that I would encourage you to access. They have guidelines on what to do when you're isolated at home, both within the house and with respect to contact others. The CDC's National Institute for Occupational Safety and Health, or NIOSH, provides very explicit guidance for businesses, and that's the website there that takes you directly to that. And these are not just healthcare businesses, any businesses, especially for small employers, middle-sized employers, as well as large corporations. And then finally, the Greater Houston Partnership has opened up a WorkSafe company website as a supplement to the City of Houston ordinance, the Stay Home, Work Safe ordinance that also contains useful information and is periodically updated. So that was just a kind of a little bit of a whirlwind update as to where things stand, and I'll be happy to take your questions from here on out. So,
all righty, thank you, George. So I think what I'll do, I think I just put it back on the title slide for everybody. We would love to show ourselves on our webcams, but it's just not wanting to cooperate with us. So we'll just go ahead and talk through everything. So, you know, as we answer some of these questions, George, let's, for the sake of time and discussion, let's assume that, you know, everybody on the call wants to take zero risk that they allow a sick employee into their office or their company or to their job site. They don't want to take that risk. So let's assume that the risk they want to take is zero. They want to take every precaution that they can to prevent the spread of the virus in their workplace. So as I pose these questions and to Dr. Delclos, there may be some scenarios where the guidance is not very clear as to when to return an employee to work, and it may be left up to the comfort level of that employer. But instead of going through many different comfort level scenarios, we'll assume that nobody wants to take a risk, right? If somebody is sick and may spread that virus to other people, nobody wants that employee back in the office until we know that they are completely safe as much as possible. So George, again, thanks for being here. Let's jump right into some of these questions that people had written into us. I think you gave this update, but maybe just want to summarize it in a sentence or two. How are we doing in Houston? How are we doing right now in Houston? Do we think that that number is going to exponentially increase over the next couple of weeks?
That's a great question, and it's also a very timely question. I don't know if y'all had a chance to look at the front page of the Houston Chronicle today, but there is an article on a study, a modeling study that comes from the place that I work at, the University of Texas School of Public Health, that was spearheaded by our dean, Dr. Eric Borwinkle, that is being used to make projections of how the cases will evolve in the Houston area. And now, of course, they don't know for sure, and there are a lot of assumptions that are made in these models that may or may not turn out to be true, but they're based on the best evidence available to our knowledge at this point, and using very sophisticated modeling techniques. So basically what that article says, and I just took a quick look at it this morning, is that if we continue with the measures, the interventions that the city has put in place and that the hospitals have put in place, even before the city ordinance, things like, working from home, encouraging businesses to have their employees to work from home, staying inside, social distancing, etc. If these are effectively complied with by the citizenry of Houston, that we may, with those interventions, we may hit about 3,500 cases, and this is Houston, with an expected peak of these cases around the 7th of April, and with a projected end date of about May 12th. If we don't implement these interventions, if they're not complied with, if we don't implement them successfully, or they are delayed by as little as 1 week, then those 3,500 cases could jump up to about 24,000 cases in Houston. I'm not saying this to be an alarmist at all. These are projections. I think there's a lot of good news here in the sense that it really makes the case for these difficult to take, but simple to conceive measures that all of us have the responsibility of taking as individuals, as companies, as healthcare professionals, that they can have a great effect. And we're in a phase now with the COVID epidemic where containment is not the objective. What it is what we call mitigation. So I think everybody's heard on TV this concept, this term used of flattening of the curve. What we don't want to happen is what has happened in Italy and Spain, for example, where the increase in number of cases on a day-to-day basis was so accelerated that it overwhelmed the health systems, the capacity of the health systems in those countries. That means they overwhelmed the number of available beds, the number of available ICUs to take care of the sickest patients, the number of ventilators to put those sickest patients on. We're not proposing to go to zero tomorrow, but what we are proposing is to avoid that rapid increase, and that's what's behind the idea of social distancing and all of the measures that we've been talking about, so that instead of just thinking about zero cases, what we're trying to do is just accept the fact that there are going to be cases. We're going to try and minimize them as much as we can, but especially what we're trying to do is to spread them out over time, so that there isn't this big sharp peak. Because if we spread them out over time, the goal is that we can keep taking care of these patients, but at levels that are below the capacity of our hospital so that they don't get saturated. That's what the real goal is. So far, we are doing okay, but it's early in Houston. I think when this is all said and done, I hope to be able to say that the plans that were put in place that started over two months ago, people sometimes don't realize that, made a difference. But those are the numbers now. 3,500 total cases projected by these models with all of their limitations, but at the same time based on the best evidence possible, with a peak around April 7th, and then slowly declining until we, projected end of around May 12th. If we don't, then that number goes up by a factor of 6 to around 24,000.
Wow, and I think that's invaluable information for our audience to know, because we had several questions. When do we think this is going to end? When can we go back to work? When are the industry is going to be open again, in full capacity? So I think that gives us a good gauge of if we do what we need to do, that maybe by the middle of May we can be back to normal. So that's great information. Can you explain the difference in the CDC lingo when they talk about a self-quarantine versus a self-isolation for 7 days, and the self-quarantine for 14 days, and then home isolation for 7 days? What is the difference between quarantine and isolation?
Another great question. So isolation at home is what you do when you think you've been exposed to someone, and you think you've been exposed to, and you're at a certain risk of developing the infection. But it also applies, isolation at home, to what we're doing now. I mean, staying at home is part of isolation, of social distancing, and we don't necessarily need to have been exposed to anyone. In contrast, quarantine is when there is a real risk to you of acquiring the infection because you have been exposed to a known case, or you already have the infection. But when you have the infection, you're sick with it, then for the 14-day thing goes out. You're still in quarantine because you're at home, but you may not, 14 days may not be enough for you to get over that infection and go home. So it has to be played by a different set of guidelines. But when you're quarantined, it's because you are suspected to have the infection. Most of these infections are mild, but that's what quarantine typically means. It's to isolate people who are sick, and that means, or are very likely to become sick, or they have symptoms and they haven't been able to be tested because there's a shortage of tests. So we just assume that they are sick. And in that quarantine, it's what we do is we isolate you from the healthy portion of society, but that also means that you have to take measures in your own home with respect to minimize the interaction with other family members, your loved family members. There are ways that you can interact, but there are also ways that you should, but there's also an emphasis on staying isolated. So for example, what we recommend during a true quarantine, again, this is somebody who is sick, that they stay in a bedroom by themselves, ideally with their own dedicated bathroom, that while that person is in their room, they don't need to be wearing a mask, they're by themselves, etc. But when they interact with family members, because they're going to leave that room periodically, that they wear a mask, that anybody entering the room, a family member, to take care of you or to just say, hi, or to pick up dirty laundry, etc., also be wearing a mask, and dispose of those linens separately, that you also try to use to keep your eating utensils separate. These are all smart things to do, and that you clean frequently those surfaces with simple disinfectants and cleaners. That's true quarantine. Isolation, on the other hand, actually all of us are to a certain extent are practicing isolation right now, even if we're not sick and even if we have not had a known contact. That's part of social distancing.
Okay, a question that I get asked all the time is, and I think you touched on it in your introduction, we know that the US each year is going to get hit by a regular flu season. It's going to infect, up to 30 million Americans every year. We know that statistic. So why are we so panicked about this virus that has only infected a fraction of that number of cases? Why are we so panicked about this virus and we're not so panicked about the flu virus every year?
Yeah, well, we're not panicked about the flu virus. That's true. We are concerned about the flu virus every year. The reason we're not panicked about the flu virus is because we have a lot of knowledge about the flu, its seasonal patterns, its infectious rate, its mortality rate, and we also have treatment and vaccines for it. So vaccination for the flu, and as an example of how serious we take the flu every year is this now several year campaign to get folks vaccinated for the flu when it's time to get it. We usually start around September. The flu season is now towards the end in Houston. It still hasn't gone away completely. It is still useful to get the flu vaccine. And we have had a lot of people presenting to our clinic, for example, with symptoms that they thought were COVID related, and we've tested them and it was the flu. So it's still going around. So knowledge of all of this really helps us not panic about the flu. In contrast, the coronavirus, the novel coronavirus, the one that's responsible for COVID-19 infection, is a completely new virus. We don't have a vaccine, at least not as of yet. We don't have scientifically demonstrated effective treatment, although there's a bunch of treatments that are being tested right now as we speak, including in Houston. And we know that it has a higher mortality, likelihood of death, of causing death, than the flu does. The flu has a mortality rate of around 0.1%. And although the estimates have ranged widely for COVID, it's at least 10 times more fatal. So at least 1%. When the epidemic started, we were quoting higher numbers of around 2 to 3%. Because it was based on numbers coming out of China, their number of confirmed cases, and their number of deaths. We divided one by the other, and it roughly came out to 2%. But as testing became more available and the spread to other countries increased, in some countries they tested a lot more than they did in other countries, and the U.S. actually is still under testing. But if you look at South Korea, for example, they had a massive campaign where they were testing anybody that wanted to be tested. They came up with this idea of the drive-through testing where you don't even leave your car, which is being implemented in Houston now, by the way. And anybody who wanted to, even if they didn't have symptoms, could be tested. Now in the US, we have a shortage of testing kits, so we can't test that many people. But the reason I'm mentioning this is when you test a lot of people, your denominator, the number of confirmed cases, is going to be larger. And so you take the number of deaths and divide it by the number of confirmed cases, and that mortality rate may well be below 1%. A very important consideration, though, with COVID is that 1% is not evenly distributed across all age groups. It is very, very low in teenagers and adolescents, and then it starts to creep up. One of the big increases is after you're about the age of 60, it goes from about 1% to 3%. And if you are over the age of 70 or 80, it jumps up to 15, 16, 17, 18%. That's a lot of folks.
Wow.
And if you happen to have a chronic underlying disease like heart disease or certain lung diseases like COPD or emphysema or lung fibrosis or diabetes even, then your risk is also increased. Now, for a long time, and then with this I'll finish this question. We were saying that the younger groups, as I mentioned, have a lower mortality rate, and that's certainly true for teenagers and adolescents. But we're also seeing with the data from the U.S., especially from New York, that doesn't mean that they are immune or that 40 and 50-year-olds are not immune. In fact, a sizable number of hospitalized patients with COVID in the New York area are in that 30 to 40 to 50 year age range. Now, they should have a lower mortality rate, but that tells you that the infection is already severe enough to get them hospitalized. So bottom line is there are important differences between the flu, which we control. We know it has a seasonal pattern, and COVID, where there's still a lot of unanswered questions. It is spreading very fast. It has a higher mortality, and we don't know if it's going to have a seasonal pattern. I hope it does, because then Mother Nature may also lend a hand in controlling this as the warmer months come in, but we don't know that right now. First, when we started looking at the distribution of cases, I was kind of optimistic because most of the cases were in the northern hemisphere and relatively few cases in the southern hemisphere, like in Australia, New Zealand, South America. But that's all changed. Now there are cases everywhere. So it still remains to be seen whether it'll have a seasonal pattern. I really hope it does, but right now we don't know that. So there are important differences.
Sure. A question that we got, concerning employees that are sick. If I have an employee with signs of an illness, maybe they have fever and cough, but they go to their doctor, the doctor doesn't have the test, they can't get tested. So we know they're sick. The CDC has some guidance out there now saying that, well, you can be home if you've been home for more than 7 days from when your symptoms started, you don't have any fever, your symptoms are better, then that's one of the ways that we think you're okay to go back to normal society and maybe even work. What do you think about those guidelines? Are those good for employers to reference? If my employee's sick, but it's been 7 days now, he doesn't have a fever for the past 3 days, he's feeling better, is he safe to come back to work?
I think they are very good guidelines with the information we have available now. As a matter of fact, we are applying them. I would counsel, however, employers to allow the healthcare provider, the doctor, to be a part of this decision making at the end. I would personally require return to work notes from a physician or from a healthcare provider. But Tommy, what you were saying is correct. So the CDC has an algorithm for returning to work of people who, and it's important to say, these are people who we assume had COVID or were confirmed to have COVID.
Right.
These return to work guidelines don't apply to people who still have respiratory infections or even the flu. I think we can be a little bit more generous with those. But so one of the rate limiting steps in returning to work is, can you test people before, or should you test people before they come back? And the answer is, in the best of all worlds, if it's a confirmed COVID case, only if it's a confirmed COVID case, yes, we should test them. But the reality is that right now, there's still a shortage of testing. So we're reserving testing for selected groups, especially the healthcare providers, because we want those folks to come back to take care of sick patients with COVID, but to do it in a way that they don't endanger other patients in the hospital or their co-workers. And so I can tell you, for example, Memorial Hermann at the University of Texas, we are requiring, fortunately, we have a teeny tiny number in this situation so far of infected healthcare workers, very teeny tiny, but we're doing the swabs to come back. However, the majority of people are not, and including the family practitioners, the primary care practitioners out there in the community, won't have access to that return to work testing, at least not now. We hope that will change. And so you have to rely on other measures in the absence of that test. And the guidelines there are, and again, we're only talking about a confirmed or suspected COVID positive person. And that is that, number one, at least 7 days have elapsed since the symptoms first appeared. So they're going to be out for at least 7 days. Number two, that they be fever-free, without a fever, for at least 3 days, 72 hours. And that fever has to be, and that temperature, or that absence of fever, excuse me, has to be documented when they are off fever-reducing pills, like Tylenol, like Aleve, like ibuprofen, Advil, all of those. They have to be off of them and then be fever-free for 72 hours. And they have to have improved, especially with respect to respiratory symptoms such as cough or shortness of breath, also for 72 hours. So in contrast to that, when we do the swab, the testing to see if they can come back, those 72 hours become 24 hours because you're much more certain that they're free of the virus because you're going to have a negative test before they're allowed to go back. So those are the two extremes. So that is for COVID positive patients. If you have somebody out for the flu or for a bad cold, then I think what your usual return to work policies are also apply here. And, a lot of places require that they be without a fever for 24 hours, or depending on the number of days they've been off, they have to go get a note from their doctor, et cetera. And I think those things still apply. But what I'm talking about is when it's a confirmed positive or highly suspected COVID positive patient.
Gotcha. And I think we'll talk, I think there's a question later on about symptoms, and can you always trust the cough and the fever as symptoms? So I think we'll get to that a little bit later. Next question was about transmission rate. If my coworker is known to have tested positive for the virus, and I know that I sat across him or her at a desk for a week and sat across in the meetings, and we went to lunch together, we had a lot of close contact, how likely am I to get the virus?
So there's a measure that we use in epidemiology of infections called the R naught value, R, just the letter R. And what that number represents is the number of people that you would expect, on average, that you would expect that one person with the infection can transmit the infection to. For the regular flu, that is about 1.5 people on average. So for every person that has the flu, that person can infect 1.5 other people on average. Obviously, there's no such thing as half a person, but this is an average value. In contrast, COVID is for the COVID virus, the R value is closer to 2.5 to 3. That means every one person can that is sick with coronavirus, novel coronavirus, can spread it to 2 to 3 other people. Obviously, they may be able to spread it to 10 people or to none, depending on their circumstances. So that's the average value. And then there are characteristics of the exposure that you've sort of alluded to, Tommy, in your in reading out the question, that need to be taken into account. So, for example, casual encounters in a hallway where you say hi to somebody and you pass them by and you maybe chat with them for 15, 30 seconds and they're not visibly coughing and stuff like that, that is probably minimal risk. However, being in close proximity to another individual, and our rule of thumb is less than 6 feet, for prolonged periods of time, that means more than just a few minutes of a casual encounter, and especially if that person was actively coughing or sneezing, all of those things increase the rate of contagiousness. What we do, and we've done now several exposure evaluations in the Med Center, is we ask these questions to try and classify people into some CDC categories of risk of exposure, of acquiring the disease. And there's a low, medium, and high based on a combination of factors. One is proximity, another one is duration of the contact, prolonged contact. Another one, which is unlikely to occur all that much outside of the med center or the healthcare setting, which is, was the person who was sick wearing a mask? Were they not wearing a mask? Were you wearing a mask? Were you not wearing a mask? And we take all of those, and were you wearing other types of PPE, such as goggles or face shields or gloves or gowns? And we take all of those factors into account, and there's a table that the CDC has that we don't have time to get into, but basically it allows you to classify people into these low, medium, or high exposure categories. Anybody that falls into the medium or high categories, right now, we send them home, even if they don't have symptoms. And we ask them to monitor their temperature with a thermometer, not a guess, but a thermometer, twice a day, and that they monitor for symptoms. And after 14 days from that last exposure to the patient who was sick, the person who was sick, they can come back. But if they develop symptoms at any point, then we might bring them in for testing. People, on the other hand, who are the low risk exposure level, we typically allow them to work as long as they have no symptoms. And we ask them to wear a mask sometimes, not always, depends on the circumstances, but we certainly ask them to monitor their temperature and their symptoms twice a day until the 14 days have elapsed. And if at any point during those 14 days, they develop symptoms, we pull them off the job, and then we decide whether, and we send them home, and we decide whether or not to test them. Let me add, just to finish up with, there are more and more testing sites now available than even a week ago. And so even though your primary care physician may not have the ability to test, there are places that you can go, such as Butler Stadium that the health department has set up, where they will screen you, and if you meet you or your employee meets the criteria for testing, they will be tested there. So that it's the testing availability is nowhere near the level that we want, but it's
Right.
gotten a lot better in the last week. So it is likely that as you send your employees out for evaluation, that if they meet the criteria, that the possibility that they can be tested is now much better than it was a week ago.
Well, to that same point, I know companies and large job sites are desperate to prevent any sick employee from walking into those gates and then potentially causing a huge outbreak at that site. In that desperation, I think, well, what can we do to screen every single employee walking through the gate? So I know several companies have leaned on, not only the health questionnaires, but checking people for fever when they enter the gate. What do we know about fever as a symptom? How accurate is it? How many are you going to catch? Are there any studies to say checking everybody for a fever is a good idea? What do you think?
So if you look at the presentation of COVID, clinically, the most common feature of most cases, I'm talking about cases that people have symptoms, is a fever. It's in about 80 to 90%. Now we used to say fever greater than 100.4 or 38 degrees Celsius for screening. For example, like at Methodist Hospital, Memorial Hospital, we're taking a value lower than that. We're going with 100 or 100.1, and that's consistent with CDC. So you lower your threshold just so you make sure you catch some folks that might not be at the 100.4 mark, but they have definitely a fever, right?
Yeah.
So that's in about 80 to 90%. Cough is present in about 80% of persons. Severe shortness of breath is much less common, fortunately, in about 20%. Some degree of shortness of breath is a little bit more common, but severe shortness of breath is present in only about 20% of confirmed cases. What makes this a little bit complicated is there are many other symptoms that have been reported with COVID, and not all of them are necessarily respiratory. So, for example, there's been a lot of talk lately about loss of sense of smell. I personally wonder about that because even a common cold can give you loss of smell and taste for a few days. We've all had that. GI symptoms, diarrhea. We did have some cases who presented first with diarrhea with no fever, and then they weren't tested because, and I'm talking about now a few weeks ago, we know better now, they presented to the hospital and they had a known exposure history. This was when I think you all heard that the first cases in Houston in the community were not community transmitted, but actually all related to a cluster of folks who had gone down the River Nile in Egypt. And this person had a positive travel history, but had diarrhea, and she was told she had a gastroenteritis, which is logical. That's what I probably would have said. Sent home, and 3 days later she came back with fever and shortness of breath and tested positive. So, there's a smattering of symptoms, but the criteria that most places are using to accept somebody for testing, and what is driving this again is the insufficient number of testing opportunities, are fever. You must have a fever, and one of two symptoms, either shortness of breath or cough. All the other stuff, and a sore throat is a third one that they've added recently. All of the others, feeling bad, muscle aches and pains, diarrhea, loss of sense of smell or taste, all of those can happen, but they're very non-specific. And because we need to be very careful about selecting who we test. As the testing becomes more available, I think you're going to see that we're going to loosen our criteria for testing, and then we'll catch some folks. There's a risk to having these strict criteria of cough and shortness of breath and fever, that you miss the cases like the one I just described. On the other hand, if we're short on kits and we start testing everybody that comes in with diarrhea to the emergency room and to a clinic, then we're not gonna have enough test kits to sample the people that do have those other symptoms.
Right. Okay. Question about immunity. What immunity do I have after I know I have the virus? Am I immune from getting that virus again if I've already had it?
We don't know for sure, but it is likely that you will have some immunity. And I say this based on a couple of things. First of all, there were some cases reported out of China where people who had had one episode of COVID then developed what they called a second episode. But when you look at that data, there are problems with the data. Some of them might have had to do with the testing accuracy, and the others may have simply represented cases, the first case that just got better, but they didn't really fully recover before they had a flare-up of symptoms again. So it was really a continuation of the first infection. On the other hand, these are described in small numbers. And so we're seeing that, for example, in China now, cities are opening up again, et cetera, and they're not having reinfections. Now that's different from what some of the public health authorities call a second wave. We'll talk about that a little bit later. But reinfection, and the other source was Dr. Fauci, Anthony Fauci, the head of the National Institute of Health's Center on Infectious Diseases, or Institute on Infectious Diseases. And he's been a virologist he's outlived 6 presidents so far. And I remember hearing him for the very first time in 1984 at Baylor College of Medicine. He gave a talk on this strange virus that was only affecting primarily people who were homosexual or IV drug users, and that we now know as AIDS. And it was a brilliant talk. And so I've respected him my whole life. He's a very good, trustworthy source of information. He is also a world expert in virology, the study of viruses. And what he says is, look, there's got to be some immunity. Just these numbers suggest that although reinfection may occur, it's unlikely given the numbers. Now, what we don't know is how long that immunity lasts. Is it like the measles, where you have it once or you get vaccinated and your immunity is for life? Or is it just a seasonal immunity because next year another different strain of the virus comes and then you're not immune to that new strain? That's what happens, for example, with the flu. You get the flu shot and it protects you for this year's flu, but next year's flu strain may be different, so you have to have a different vaccine for that. But the likelihood is that there is immunity. We just don't know how long it lasts.
Gotcha. Okay. Keep our fingers crossed. There was a question on air filtration in buildings or in offices. Is putting a HEPA filter in an office room, would that do anything to help lessen the virus transmission?
I think doing that is much less important than doing other things. We need to understand how this virus works, how it is spread. When you have a respiratory infection, the way that you spread viruses can be through coughing, sneezing, maybe coughing or sneezing on a surface, and then somebody touches that surface and then touches their face and gets the infection. Coronavirus is spread by what we call droplets. These are the typical stuff that you see in the air when you sneeze and you see all those little particles. Even though they seem tiny to you, they're actually huge. They're very large, and they rapidly drop to the floor or to the ground. Usually within a distance of they probably go farther than about 3 feet, but we always say 6 feet to add some protection. These are that's what's called droplet transmission. That is very different from other viruses, where the virus, when you sneeze or you cough or you even breathe, exhale, it forms an aerosol. An aerosol is a much, much tinier particle, and it tends to stay suspended in air for a long period of time. With viruses that are transmitted through droplets, really having HEPA filters isn't going to help much at all, because it'll never make it to that intake, or it'll never make it to the filter because it'll drop within about 6 feet. If, on the other hand, we were talking about an aerosol, then yes, for aerosols, HEPA filters can be useful. But coronavirus, novel coronavirus, transmits by droplet. There are some exceptions where it can become aerosolized, but most of these exceptions occur in hospitals. So, for example, if somebody is so sick with COVID that they need to go on a ventilator and they need to be intubated, then that process of putting a tube down their throat causes the patient to cough. It can generate aerosols. Or when we treat patients with nebulized bronchodilators, medicines that are given in a nebulizer, that mist that the nebulizer creates is an aerosol. So in those cases, we increase the level of protection of workers around them because it's an aerosol. In those cases, a HEPA filter nearby HEPA filter might help. But for the run-of-the-mill business out there, I mean, it's nice if you have a HEPA filter, but it really doesn't do that much good, and certainly is not a substitute for the other safe practices that we've been talking about. Social distancing, cover your mouth when you cough or sneeze, good hand washing, and disinfecting surfaces.
Okay, so it looks like we are right at the 30-minute timer. So several more questions, so we're going to try to run through these pretty quickly. What about work-relatedness? Can coronavirus be considered a work-related disease or illness and covered by workers' comp?
I can answer that for the healthcare setting. So in the healthcare setting, and I'll give you a good example, if one of our employees, one of our doctors, nurses, gets COVID and they clearly got their COVID because they went to a conference or they went on a cruise, that's not work related. However, if they get it from a coworker or from a patient, we do consider that work related and we do run it through workers' comp.
Right, and I'll just add on that I looked up the Texas Department of Workers' Comp Insurance last night, and they clearly state that in general, yes, it can be. So if you have a worker that goes to work and they can prove that they got it at work, then there may be a claim there. But I think you know, to George's point, you have to prove where you got it, and that's going to be very difficult in this case because it's out in the general public.
Right. In our case, we do extremely detailed contact investigations that most employers are not going to be able to do. We have to do it because of the price we pay if this thing spreads hospital-wide.
Right. And I'll just a follow-up note on that. I won't pose it as a question, but I'm sure most people on the call know that OSHA has taken the stance that this will be a recordable illness if it is proven to be work related. So just keep that in the back of your heads. Changing subjects, there was a question regarding trash handling. You know, what's the risk on getting the virus if you're handling solid waste? I think this probably, you could expand on that and, you know, talk briefly about surfaces. You know, how likely am I to get it if I touch something that somebody sneezed on?
Right. So for example, for people in quarantine or in home isolation, what we recommend is they always dispose of their trash, their tissues that they've sneezed into, their dirty not their dirty linen, that goes to the washer, but always in a bag-lined trash bin, and then you close those like we do, like most of us do for our day-to-day garbage. There have been studies that have been done about how long the virus lasts on a surface. Some are very detailed studies. The quick answer is it can last on certain surfaces from a few hours to maybe 2 or 3 days. I think you know, our hazardous waste, not the hazardous waste, our solid waste disposal co-workers in Houston. Well, now it's mostly automated, so that in and of itself, automated you know, side loading trucks will decrease their exposure. But if they have to handle bags and things like that, they should wear gloves, but they wear gloves anyway. Yeah. I don't think that for surfaces, necessarily wearing a mask is helpful. If they can, and just a regular mask would be fine. But really the contact part, as long as they're wearing gloves and washing their hands and trash is kept in a bag, and most of it is done automatically loaded, you know, disposal rather than them having to grab the bags, they should be okay. But sure, it will last on surfaces, but not as long as people think.
So for those people who have a lot of janitorial workers, you know, and they're wearing gloves right now and, you know, doing as much as they can that way, it sounds like there's not a lot more that they should do to try to protect themselves.
That's correct. Now that's going to be very different from our housekeeping crews in hospitals, because there obviously the risk is much higher. The likelihood of coming into contact with the COVID virus is much higher. So we fully protect our housekeeping crews, and more so than when they usually clean. So they've got masks and gowns and gloves and face shields or goggles on when they're doing their cleaning there. But it's a different ball of wax. It's a different ball game.
Okay. So talking about the accuracy of the coronavirus tests, if my employee gets tested and either gets a positive or a negative, how confident should I be that that test is accurate? And I'm sure most people are worried about the negatives. If somebody says, I got tested and I'm negative,
Yeah.
how accurate is that negative test?
Well, let's start with the positives. Although there can be false positives, we always err on the side of precaution. So a test is just one piece of information. Granted, it's a vital piece of information, but as clinicians, as doctors, we don't rely just on the test. We try to put together the entire picture. Does it fit? Is the person sick? Do they have fever, shortness of breath, cough, etc.? All the stuff we talked about before, and they have a positive test. So the likelihood that in that scenario that a positive test is a true positive is extremely high because it all fits. Where it gets a little bit tougher is when you are talking about a test in a person who does not have symptoms or who has symptoms that are not typical of COVID and might be due to something else. In those cases, in the majority of cases, a negative should reassure folks. It's also true that we might have caught them in an early stage of the disease, very early, where they didn't. Well, right now we can't say when they didn't have symptoms because in the US we are not testing asymptomatic people without symptoms because of the problem with the test kits. But if they have some non-specific symptoms and it comes back negative, there's a chance that if those symptoms progress and you retest them, they can go from a negative to a positive. There has to be a starting point with everything, right? But I think you have to take it into context and look at all of the information. So somebody that has very vague symptoms and their test is negative and they seem to be getting better, because there's a waiting period to get the test results. And so that person, while they're waiting, they're either going to get worse or they're going to get better. If they're getting better and you get back a negative test, that should be reassuring that it's a true negative.
Good.
If that person is getting sicker and sicker and sicker with symptoms that are suggestive of COVID and your first test was negative, then it's probably a good idea to retest them because you may have just caught them too early before the test reached that threshold where it's
Right.
detectable.
Okay. Here's a question I think right up your alley, George. How can we tell the difference between simple allergy-related symptoms, cough, congestion, runny nose, I feel bad, and then true COVID symptoms? We know that the range of symptoms can be all the way from no symptoms to every symptom under the sun. So how do we distinguish? And I realize this is for a doctor to decide, right? But as a doctor, how do we determine? Okay, well, I don't have a test. I can't test you, but based on your symptoms, I think it's just allergies or common cold, or I think it's coronavirus.
Right. So with allergies, that's a very pertinent question in the Houston area. We have allergens, different allergens throughout the year in different levels. And right now it's the tree pollens and grasses are starting up right now. So one of the things is, fortunately, most people who have allergies know that they're allergies because they've had them before. The duration of their symptoms is much longer and it parallels, when the levels are high and low. Typically people with allergies do not have a fever. And if they have allergic symptoms, they tend to be classical allergic symptoms. So they may have a runny nose, but what runs out of their nose is very clear and watery. They oftentimes have itchy eyes, which is not a symptom of either the flu or COVID. If they have asthma, they would wheeze, which is an allergic response. They might have skin rashes. But typically allergic folks know that they have allergies. Now, if you're dealing with a patient that doesn't know that it's allergies, but you can still take a careful history. And one of the things is the duration of the symptoms. So COVID is an infection and it's limited in terms of how long it lasts. It lasts several days, whereas allergies tend to last longer. And they, as I said, they parallel the levels of allergen in the air that is triggering their symptoms. Right. But a careful history, and especially the absence of fever, should be helpful here.
A question kind of as a follow-up to that was written in, and can you transmit the virus if you're not running a fever?
We think if you're not running a fever or you're not having any symptoms, okay? So we know that there is asymptomatic transmission of the virus, that people who don't have symptoms yet, but will ultimately have symptoms, may be contagious at that point, may spread the disease. We don't know how many days before the actual onset of symptoms, a person might be contagious, nor do we know well how contagious they might be after they get over it, because the virus can be shed from a person that's recovered completely. We know it can be shed, but shedding a virus doesn't necessarily mean that the contagiousness is there. The test that is used to detect COVID is very sensitive. It's based on a method called PCR. And it may pick up viral particles that, yeah, they're there, they can be detected, but you don't know that they're infectious. The likelihood, however, is that you are most contagious. I mean, we know it's not the likelihood, we know this for a fact. You are most contagious when you have symptoms. Why? And that's because those symptoms are reflecting a very high number of virus particles, what we call viral load in the body. And the greater the viral load, the greater the number of viruses that you have in your body, the more likely you are to spread it. Before symptoms occur, they're likely to be much, much lower, so the risk is less, but that doesn't mean it can't happen. And right now, there is no good way to know that. Once this is all over, we're going to go back and look at all of the data and see which cases were associated with somebody who at the time didn't have symptoms, but then later went on to have the symptoms and develop the disease. And you can do a lot of epidemiological study to get a better handle on that. We've done that already with the flu. We've known for many years that you start becoming contagious 1 to 2 days before you actually develop the symptoms of the flu. But that type of knowledge is not here yet for coronavirus, for this type of coronavirus.
Is there anything other than bleach or Lysol that we can kill the virus with? Alcohol, vinegar, ammonia?
Okay, not vinegar. Normal household cleaning agents and disinfectants, including Lysol, including bleach, will kill the virus. You don't have to go to anything fancy. Vinegar is not a disinfectant. It'll make your surfaces clean. It's a great degreasing agent for some things, but it's not a good disinfectant. So common household cleaners available, well, they used to be available anyway, in stores, should work. And if you don't have that, soap and water will work as well. Good cleaning. A lot of getting rid of viruses on surfaces. People think, well, we want something that kills the virus, and ideally we do. But simply scrubbing an area removes the virus as well. You may not kill it, but you're removing it. And so soap and water, when you don't have anything else in terms of household cleaning agent, will work fine. Okay. And soap and water are also the first line of defense with hand washing. There's been this problem with skin sanitizers, the shortage, but that's because I think people forget that the first line is soap and water, and soap still has not disappeared. You use a skin sanitizer when you don't have soap. You don't do it when you have soap, right? And so it behooves all of us to conserve skin sanitizer for those situations which they're really needed.
All right, we had several questions about how to best communicate with your company, how to help manage emotional toll and stress on these employees. Any quick tips you could give on that?
Yes. So again, I said that the CDC, the Centers for Disease Control and Prevention website for COVID has wonderful resources there. And one of those resources has to do with dealing with anxiety, mental health issues, and stress, either because of the concern of the epidemic or because you're isolated at home, you're in quarantine, et cetera. And there are several good tips there that I'd encourage you to go look at them and read them and apply them. One of the most important ones is don't listen to the news all day about coronavirus, because you'll go nuts. Just maybe portion your time. You're just going to listen to the 6 o'clock news or something like that. I mean, you have to stay informed, but you don't need to be bombarded all day with something that just perpetuates your stress. On the other hand, employers, especially larger employers, often have wonderful resources, including their EAP programs that they can offer to their employees who are having a rough time of it. And just because you're at home doesn't mean that you couldn't call up your EAP provider, just like we have teleconference meetings or video conference meetings, et cetera. I'm sure that should be available. We're doing a lot of our visits in clinic or clinical visits nowadays remotely through telemedicine. Dr. Heisler has a great system in place for telemedicine right now, and a lot of psychologists are doing their visits over, a secure video connection. So EAP should be able to do the same thing. That doesn't mean everybody has to go to the EAP. I think if you go to this guidance that the CDC has provided, simple common sense measures, establish a routine, and they're all designed to minimize the stress and also the distortion to your daily life that being away from the workplace entails. And you can get back into a similar routine, but from your house. So I'd encourage all of y'all to look at that. Just go to that website I mentioned. If you didn't catch it, just say CDC COVID anxiety or CDC COVID stress, and it'll take you right to those recommendations.
Great. All right, we're at the 15-minute mark, so we'll try to do some fireball questions and answers real quick to finish some of these out. Question, this was from one of our physician colleagues that we know. Are there any updated recommendations for periodic surveillance exams, such as DOT exams, OSHA regulated asbestos exams? Have any of those stopped from those governing agencies that we know of?
And that is a wonderful question for Dr. Tommy Heisler.
And the answer is no, they have not. Not at this point. Nothing that really has come through those agencies that I've seen that has stopped. I know the American Occupational Environmental Medicine group has sent a letter to the Federal Motor Carrier Safety Association suggesting that non-essential DOT exams be paused for a while, but I have not seen any response or any definitive action. So right now, if you have to have a physical exam and OSHA says you do, you still do. So we're, at least in our healthcare clinics, we're taking extra precautions, obviously, just to make sure everybody is safe and healthy, but they have not stopped yet.
The one caveat might be, Tommy, that you and I were talking about is spirometry, so pulmonary function tests that may be a component, for example, of an asbestos exam.
Right. If there are non-essential tests that have to be done that may put the technician at a higher level of a risk, then we've decided to pause those based on some guidance from the American Academy of Occupational Medicine. But as a whole, those physicals are still being regulated. Next question. I think we talked about that one here. Let's see. To follow up on respirators, what type of half face and full face respirators will filter the virus?
Well, it's not so much whether it's a half face or a full face, it's what cartridges you put on them, right?
Right.
So typically, you want a filter that filters out particulates, right? So a HEPA filter, now I know what I said about HEPA filters earlier, those were area HEPA filters or in the ventilation system. But I think if you have to go to the cartridge respirator to protect yourself from coronavirus, that's usually because you've run out of what we normally use, right? Which is a surgical mask, and we haven't talked too much about N95, so maybe we can put in a word or two before it ends because that's important. But if you're out of those and you have to go to an elastomeric cartridge respirator, then the right type of filter is a HEPA filter for that because it's designed for particulates.
Okay. Let's see. For people that let's say they know they have the coronavirus and they're staying home, they don't feel good, is the recommendation regular medications for cold and flu, like you would take if you had a cold or a flu?
So these for mild cases of COVID, which again is about 80% of the cases, at least in the world literature, 80% of cases don't need to be managed in the hospital. They can be handled at home. What you do is you take the over-the-counter medicine that is geared at the symptom. What symptom is bothering you the most? Is it the general feel bads? Well, and fever. Well, you take Tylenol or ibuprofen or naproxen, right? Aleve. And I know that there's been some stuff out there saying that you shouldn't take anything but Tylenol because ibuprofen and Aleve, and those are anti-inflammatory, and it interferes with the body's ability, or the lungs' ability to face the infection, that's actually not true.
Gotcha.
Any of those fever lowering, pain relieving meds are good. I would keep up my fluids. And then if you have a particularly nagging symptom like the cough, well, then you take a cough remedy. It can be over-the-counter dextromethorphan, which is in Mucinex DM, or cough syrups that have the initials DM on them for cough suppression. And yes, you can also take the severe cold and flu remedies that are available over the counter in any pharmacy, but geared towards the symptoms.
Okay. A bunch of follow-up questions. I'm now on the questions that people are inputting live. Can you reiterate in the last 10 minutes that we have about surfaces? There was questions about paper. You know, at job sites, people have to pass around permits and clipboards. You know, should they be concerned? And how long does the virus live on surfaces?
Okay, so we talked about surfaces. It can live on surfaces. It can live on the length of time varies from one surface to another. So for example, cardboard doesn't appear to be much of an issue. So people worried about their Amazon packages and stuff like that. It's really not much of an issue. It's especially with how long it's taking Amazon these days. You know, the time has already passed that the virus would be active anyway. But surfaces that are non-porous, countertops, etc., can last longer. There, the key is, again, good hand washing, so that when people pass stuff off one to another, they've washed their hands. The other one is good disinfection and cleaning of surfaces, regular disinfection and cleaning of surfaces. So there, things like wipes, Clorox wipes and those types of things, they should be used frequently if you have them for these things. In addition, you know, the more you can do through your computer and digitally and electronically, and the less you have to touch, the better, just as a general principle. I don't want folks to get paranoid that every time they pick up a clipboard, it's going to be infected with something, but use common sense and minimize those types of interactions if you can.
I will say that I saw on one of the news conferences with Dr. Fauci, he specifically did say that they've tested it on money, and it does not appear to be enough transmission to make you sick with money. They checked it on mail, and he said he was not concerned about a transmission from money and mail. So hopefully that makes us all feel a little bit better that the head guy is saying it's okay.
Yeah, but the money is actually a very good example. So it's not transmitted on money, but geez, if you can use your credit card, then you don't even have to worry about that. Right?
Absolutely. And I know some locations are not taking cash right now.
Right.
You know, as well.
Right.
Let's see here. I'm trying to go down to some of these here. There's a question about contractor requirements, specific training. I can speak a little bit to that. And the question was specifically, should we be extending the expiration dates on that? Those expiration dates, for the most part, are set by the owner sites. They are set by governing agencies like OSHA. Sets when you have to have that training redone, or they're set by the companies themselves. The safety councils very, very rarely set our own expirations on those items. So if you think there needs to be an extension, I would get with one of those three that I mentioned. I do know some of the local sites have extended some of those expiration dates, and they're going to have you take care of that in another 60 or whatever amount of days. But for the most part, the safety councils themselves don't set those guidelines. Let me see, I'm scrolling down here. Is it helpful to use albuterol to fight the severity of COVID-19?
Well, if you have asthma and you're wheezing, yes. If you don't have asthma and wheezing, first of all, it's going to be hard for you to get your hands on albuterol because somebody has to prescribe it. It's not an over-the-counter med. And second, it's probably not going to be as helpful to you. And actually, the risk-benefit is albuterol can cause some, they're side effects. They're mild, but they can cause heart palpitations and tremors and things like that. Unless you have asthma or COPD or something where you are already prescribed albuterol, I don't think it really has a role just yet. Now, if you develop wheezing and you go to your doctor and they say, hey, an albuterol inhaler would help, then I agree with that.
Yeah. Okay. What same line of medication, guaifenesin, that's in, Robitussin, it's in Dimetapp, it's in Tylenol, cold and sinus. Any benefit in taking that early to help lessen severity?
And Mucinex as well. So yeah, well, if you have congestion and like you have phlegm and you can't get it up, then it can help loosen it. So can lots of fluids, water and all that. Are also, people forget that also fluidifies tough to get rid of mucus. So yeah, but if you don't have the congestion, it probably doesn't help.
Sure. A question from a CEO of a company wanted to know, how are different companies communicating amongst themselves? Are they sharing critical safety messaging to their workforce? And maybe George has an answer to that. I have not seen one. The Safety Council is here just for that. We're here to be a network amongst our members. So if you think there's something that is important safety-wise that needs to be shared, please send it to us. We will be happy to take a look and disseminate it if it's of value. But we would love to be able to help mitigate or streamline some of those safety messages. Safety is not private, right? We want everybody to know helpful tips.
Right. Let me just add a couple of things to that. So it would be wonderful if the employers did form some sort of network. I think that's obviously what the Safety Council is doing that you mentioned, Tommy, and also the Greater Houston Partnership. Their website, I think, is trying to try to bridge across different companies. At the medical center, we've been doing this again for two months. If you think about it, there's a myriad of institutions. In the Texas Medical Center, there are 100,000 healthcare workers. That's our worker population that we have to take care of, but there's a myriad of institutions. So early on, we had to come together and form incident command groups that bridged across different hospitals, universities, medical schools, et cetera, because our people go from one place to another all the time. And so there it was a necessity. And I think it's a pretty good example of how that can be, of the importance of binding together and sharing experiences and practices. And one of the most important things I think you can do as employers, if you fall into this category of being an essential business and you're abiding by the 10 principles of the stay home, work safe policy, it would be good for you. I would encourage you to actually publicize that, publicly declare that you are pledging to fulfill those 10 principles, and that will set an example for other companies.
Perfect. Several more questions that I can try to knock out in the next 3 minutes that we have. UV lights, any guidance on, would UV lights help anything kill the virus?
Yeah, well, so they've been looking at UV lights with this virus, and the final word is not in. What I can tell you is from experience from other diseases, especially tuberculosis, UV lights can, in some circumstances, sterilize or kill off microorganisms, but they are always a secondary line of defense. They never substitute for the main measures of, the main practices that we've talked about here: social distancing and cleaning surfaces and washing your hands and covering your mouth.
I think we're down to our last 2 minutes. Several questions that we didn't get a chance to answer, but we do have, the system allows us to identify who asked the question. So we will try our best to send that answer to you privately. I do have one, is fit testing required for N95 masks? I think that OSHA gave some guidance along the lines of you probably shouldn't be fit testing N95s so we don't waste the N95s. Is that right?
Yeah, so with a quantitative fit test, which is what most places use, you have to actually make holes in the mask, right? That's right. Still the way it works, right, Tommy? Right. So for example, at UT, I was just fit tested the other day, and we went with a qualitative test where you put a hood over and they spray a detectable chemical in there, and that preserves that N95. We should also be using N95s. We should be saving on N95s if we can, because there's a huge shortage for the people on the part of the people who need them most, which are healthcare workers taking care of sick patients where there are aerosol generating procedures. We don't even give the N95 to all healthcare workers that are dealing with COVID patients. Only those that are intubating them or giving them a nebulizer treatment or things that generates aerosols. Everybody else wears a surgical mask.
Right. Well, we are right at our 11:30 mark. I don't know if this system shuts us off automatically or not, but what I'm going to do is go through all of these questions and make sure that Dr. Delclos is able to write you a short response to them if he can, and unless we've already answered them somewhere in the discussion today. I know that we've recorded this discussion, so I will see if that can be posted to maybe our website if that's possible, so everybody can view it. If you missed something or you had to leave and come back. But I want to thank Dr. Delclos for being here. He brings an invaluable knowledge base to this disease, and I know we're all going to get through it and get on with our lives and get our industry back functioning to full capacity. So thanks, George. Appreciate it.
That's right. And just a reminder, everybody has to do their part, please. We can do this. We can really do this. We want to get to those 3,500 cases or less that were predicted in this morning's paper.
All right. Thank you very much, everybody. Stay safe, stay healthy. Have a good week.
Thanks.